Good morning, everyone. I can't see your faces. I got my computer glasses on, so I'm assuming you're all neuroblastoma families and doctors and everything. I want to welcome you to, I think it's our 20th Parent Education Conference, and I'm very, very happy that you're here, very sad that you're here, but happy that you're going to be able to get the information and education and knowledge that you're going to need to take on this journey. So just to give you a quick background on myself, we started Children's Neuroblastoma Cancer Foundation in 2000 after losing our son Nick to neuroblastoma back in 1999. He was in treatment for 4 years, and unfortunately not a whole lot of treatments available at that time. And so we started it because there wasn't a whole lot of information. I think we had actually one of Dr. Yannick's, Valerie Castle. I had one sheet of paper about MIBG treatment, and that was really about it. That's all we had. So that's why we started this. We got to be together as a group on an online support group, and I said, well, why don't we just meet? Why are we doing all this stuff online? Why don't we meet? And it's forged some, long-lasting relationships. We've got 20 years, almost 20 years going. So it's just a very, very nice feeling to be able to be together. And I hope you make some, friendships and everything along the way. Again, our whole scope of services to provide the resources that you're going to need. We have awarded almost close to $3 million in research grants, at hospitals across the country. That's our another main goal of ours. We have a parent handbook that we have online that was written by parents. So if you haven't had an opportunity to take a look at the parent handbook, it's an awesome tool, and resource for yourself. I've had people tell me that it was a Bible, that they used during treatment when their child was first diagnosed. We have a great medical advisory board. Dr. Yamashiro, Dr. Chung, Dr. Reynolds, Dr. Bagatelle, Dr. Julie Park, Sue Cohn, John Maris. They're all part of our medical advisory board. That's a little bit about us. Now, the next thing the way we do the conference is our presenters will be up here for approximately 30 minutes or so, and then we will do a 15 to 20 minute question and answer session after that. And what I do ask that we set up 2 microphones. If you could come up to the microphone, say your question, but keep it as general as possible. Because we don't want it to be very specific. I mean, some of the questions will be specific to your child, but we want it as broad as possible so that everybody can gain, as much information out of your question as possible, and then the response from the doctor. Let's see. We are videotaping, so just so you know, we are videotaping it, and we ended up getting it live streamed as well. So that will be available for families. And if you have questions, feel free to write them down. And if you don't want to stand up and ask a question, write it down. We'll wave it, and we'll come get it, and we'll ask the question. So if you're embarrassed or anything and don't want to be up front, because there are no stupid questions. So I just want you to know that there are no stupid questions. Let's see, use the mics. If you want to hand wipe the mics off, you can. We're trying to be as safe as possible. The other thing is, if anybody feels sick and you want to do a COVID test, Abbott donated a bunch of COVID tests for us. So if anybody's interested and wants to do it, you're free to take a test. The kids' room, they will not be coming when we have breaks. They're not going to be coming for the breaks. So any lunch and dinner and stuff like that, they'll be with you. I think they'll have a great time in there. We are doing some family photos. So if anybody's interested and would like to go down to the hall in the Oak Room, Karen Haberberg is doing family photos. So if you're interested, I think it would be a great thing to have for you. And again, the kids' room will have, they got plenty to do. They've got an Xbox, they've got all the games. They have also a face painter coming this afternoon, and then a balloon maker, and both of them are awesome, and they both donate their time to us, and we're very appreciative of that. If anyone, again, feels sick, if you want to take a COVID test, please do that. Friday night, tonight, we will be having dinner and a DJ. We get a little wild, so if you guys, if you want to loosen up a little bit, we can even do a little karaoke if you'd like. We've got a great DJ coming and everything. Again, the whole point is to relax. Get the information, relax. There's no beepers. There's no, nobody's doing this. Nobody's poking or anything. It's just relax, have a good time, and take the information. I want to thank my assistant, Nikki DiBenedetto, for all of her hard work putting the flights together. I don't know where she's at, if she's here. She's very good at that. So, and I wouldn't want to do it. It's too much work, too much work. And then thank my friend Sherry and her daughter Cassie for running the kids' room for us. Again, looks like they've had it all set up really nice for them. I want to thank our sponsors, YMABS Therapeutics, Jubilant, United Therapeutics, Friends of Catherine, the Nick Foundation, and it's just, again, this wouldn't happen, without all of our sponsors and their ability to support us in this fashion. So I just wanted to thank them, and if you want to thank them, please feel free to, go up to them. They do have some materials out on the tables and everything, so you can, feel free to take them, and there's some other books out there that are free for everyone. Let's see, Mike Elbaum for videotaping our presentation, Alvaro for live streaming it, and for all the staff here at the Weston. I just wanted to say thank you for everything. Okay, we will start our presentation. Our first speaker is Dr. Ami Desai. She's an attending physician at Comer Children's Hospital at the University of Chicago. Dr. Desai received her MD at Robert Wood Johnson Medical School and completed her residency at Yale New Haven Hospital and her fellowship at Children's Hospital of Philadelphia. Her areas of expertise are sarcomas and neuroblastoma and other solid tumor cancers, as well as developmental therapeutics and adolescent and young adult cancer care. She is a member of several associations, including American Society of Clinical Oncology, American Society of Pediatric Hematology Oncology, and numerous others. Dr. Desai is involved in many clinical trials at Comer Children's Hospital, and her talk today is an introduction into neuroblastoma. As we know, a lot of you are first, diagnosed recently, and so I think it's important that you get the basics, down to it. And if you, again, have any questions, we will go ahead and do those after her presentation. Dr. Desai.
Probably going to sit or stand to the side of the podium so I could look at the screen. Thank you to everyone, and thank you to Pat and CNCF for the invitation today, and it's wonderful to see everyone in person. My talk will basically go through, as the title implies, the basics of neuroblastoma, and hopefully set the foundation for the rest of the talks that you'll hear during this conference. So neuroblastoma is the most common solid extracranial malignancy in children, or solid tumor that's not a brain tumor. It originates from neural crest tissue, which is in the adrenal glands or anywhere along the sympathetic ganglia that traverses from the neck into the pelvis. And it is classified as a small round blue cell tumor, as you can see as to how it looks under the microscope. There are approximately 800 new cases per year in the US, and it affects about 7% of all, or encompasses about 7% of all childhood cancers, but 15% of childhood cancer mortality. So there is a disproportionate mortality from this malignancy. And about half of all newly diagnosed patients will have high-risk disease. And what we do know is that there is a higher prevalence of high-risk disease in Blacks and Native Americans. And as you can see on the right, again, this is a malignancy of infancy and childhood, and really the highest incidence is in the first year of life. Neuroblastoma has a broad spectrum of clinical behavior, and it really is reflective of the biologic heterogeneity. So from the low-risk side, where there can be spontaneous regression or treatment just may include surgery, you then move into intermediate-risk disease, which is treated with both chemotherapy and surgery. And then finally, high-risk disease, which requires intensive multimodality therapy that we'll talk about during the course of this talk. So a big question that I get from families when we have our day one talk is, why did this happen, or what is the etiology of neuroblastoma? And, there is no consistent environmental factor that has been identified. And as for genetics and family history, we're learning more and more. But what we know is that family history or bilateral or multifocal neuroblastoma occurs in a small proportion of patients, about 1% to 2% of cases. And often this is secondary to a germline FOX2B mutation. And these cases are associated with congenital central hypoventilation syndrome and or Hirschsprung's disease. And germline ALK mutations have also been identified in the majority of familial cases. But for the vast majority, it is not familial and is sporadic. However, there have been some syndromes that have been identified to predispose certain children to develop neuroblastoma. And this includes Costello syndrome, Noonan syndrome, Beckwith-Wiedemann syndrome, and Li-Fraumeni syndrome. And I've listed some of the germline mutations that can occur in these syndromes. And these are syndromes, again, that can be passed on through families. So then the question is there a role for screening in the general population? This is another question I feel that comes up when speaking to families about neuroblastoma. And decades ago, there was population-based screening in certain countries for infants 3 weeks of age to 12 months of age. And what they found was that there were increased rates of diagnosis of early-stage tumors, but this did not decrease the mortality. And virtually all of those tumors had favorable biology or tumors that may have regressed on their own. So we were now intervening in this population and potentially causing other side effects or morbidity from acting on it. So the conclusion was that tumors diagnosed in infants by mass screening are unlikely to progress to life-threatening advanced stage disease and many are likely to spontaneously regress. So populations at risk, some of the syndromes that we talked about earlier, what are the screening recommendations for these patients? So a few years back, there were consensus guidelines developed by experts in the field. And what they proposed was that for children ages 0 to 6 years of age, that they should have an abdominal ultrasound, urine catecholamines, chest x-ray, about every 3 months in that early time span in their life. From ages 6 to 10, an abdominal ultrasound, urinary catecholamines, x-rays, and do this about every 6 months now as they're sort of aging out from potentially developing neuroblastoma. And then for ages greater than 10 years, no screening is recommended at this time. As for the clinical presentation, as mentioned before, this can be very heterogeneous, and patients can have an asymptomatic mass, which could just be a mass that a parent may identify or see in the neck or on exam in the pediatrician's office. Again, it could be a mass in the thorax, abdomen, and pelvis, because that's where the sympathetic ganglia traverse. Patients may present with Horner syndrome if they have compression of one of their sympathetic ganglia. They can have spinal cord compression, which may result in back pain or neurologic deficits and is an urgent situation or emergent situation. They may have a big liver or hepatomegaly, pallor, because their bone marrow may have neuroblastoma in it, and they have a low hemoglobin. Skin lesions, systemic symptoms such as weight loss, irritability, fever, hypertension. There is a syndrome, VIP syndrome, where they can have intractable diarrhea, which is more on the rare side, and opsoclonus myoclonus, or a condition where there is neurologic symptoms that also present with a mass, as well as bone pain or limp or refusal to walk or raccoon eyes, or the bruises that you could see on the screen on the bottom right. So we talked about how neuroblastoma primarily affects younger children. However, this does present in older patients as well too, but really presents as a phenotypically different disease, or presents in a very different way. And Again, it's very rare to occur in the older population. It's more of an indolent disease course, so their tumors may not be as responsive to some of our conventional therapies. And they do have inferior outcomes compared to younger patients. And there has been some identified unique tumor biology in these patients having segmental chromosomal aberrations or ATRX mutations. And there is a need for novel therapies for this population. So as for evaluations and tests, so of course, we do a history and physical exam. We will draw baseline laboratory tests, which include a CBC or blood counts, chemistries to look at organ function, urine catecholamines. We'll often check an LDH and ferritin. And of course, we'll image the tumor, looking at it with a CT scan of the chest, abdomen, and pelvis, or sometimes an MRI for masses that might be near the spine. And as well as an MIBG scan that we'll talk about in a little bit, or sometimes a PET scan. And to get the diagnosis, we do a biopsy of the tumor in the very beginning, and bilateral bone marrow aspirates and biopsies, again, to identify where the cancer may be. And how do we diagnose neuroblastoma? So either we get the diagnosis from the biopsy and the tissue biopsy, or for certain patients where it may not be easy to get a biopsy or they may be quite ill, sometimes we can make the diagnosis with the presence of neuroblastoma in the bone marrow combined with elevated catecholamines. So many of you have heard of MIBG scans or have children who undergo getting MIBG scans. And this is a scan that detects certain types of neuroendocrine tumors. And MIBG is an analog of norepinephrine and is labeled with radioactive iodine and taken up by the neuroblastoma cells. So these tracers are taken up by the neuroblastoma cells and then help the cancer cells light up on the images. And something called a Curie score is determined based on the extent of uptake, and we'll go into that a little bit, and Dr. Yannick's talk will go into that in more detail as well. But that helps us quantify how much disease may be present. And what we do see on the scans too is there's sometimes normal uptake in the salivary glands, bladder, and liver, and that is something that we see and doesn't really represent disease. And we will make sure that our patients have thyroid protection when they get this scan before they get injected with the tracer to help protect their thyroid from MIBG uptake. So this is a little picture of what we call a Curie man, which this individual is broken up into different segments, and that helps us quantify how much disease a patient may have. And we break this down into bony lesions as well as soft tissue. So as for prognostic markers in neuroblastoma, stage and age were the very first prognostic markers, where younger children did better than older children, and those with lower stage disease did better than those with higher stage disease. And then other important prognostic markers that have developed over time was a change in the cancer cells or amplification of MYC-N, which is a worse prognostic marker than not being amplified. Ploidy, again, another type of change in the cancer cells, as well as histology, or how the tumor looks under the microscope. And these 5 factors have traditionally been used to assign risk assignment, or whether a patient should perhaps receive low, intermediate, or high-risk therapy within the children's oncology group. And more recently, an updated schema for risk stratification now includes segmental chromosomal aberrations or other types of genetic changes in the tumor cells for certain subgroups of patients. So again, as for prognostic markers for age, we sort of draw the line in the sand at 18 months. For stage, we previously used the INSS staging system, which was a surgical staging system, and have moved on to the INRG staging system, which we'll go into in a little bit more detail, which is a pre-treatment staging system. MYC-N status, histology, or again, how the tumor looks under the microscope, as well as tumor cell ploidy, and again, further biologically describing the tumor. And here is sort of how we put this together to determine certain risk groups. And this was the COG neuroblastoma risk group schema until very recently, and is still quite relevant. And again, you could see how the 5 prognostic markers help us define what kind of therapy a patient should receive. And the one thing I wanted to point out is that for patients who are greater than or equal to 18 months of age and have stage 4 disease or metastatic disease, or what we call stage M now, we know that those patients are high risk despite any of the other biologic markers. So again, age and stage, some of the earliest markers really continue on to impact or are important prognostic factors. And I'll very briefly go through our updated COG risk classification system. And essentially, these schemas start with the stage of the tumor, and again, use the common prognostic markers that we've talked about, but have added in either, again, extent of surgical resection for these lower stage tumors or an L1 tumor, or have also added in segmental chromosomal aberrations for stage L2, M, and MS tumors. And I wanted to briefly touch on the International Neuroblastoma Risk Group, or INRG task force. And this task force convened in 2005, and what it was, the goal of it was to really address the problem of non-uniformly defined risk groups, how we do things in the US versus in other countries. And there was also, through this group, the development of a pre-treatment staging system, or as I mentioned, the updated INRG staging system. And this now includes image-defined risk factors, which I'll go through briefly as well too, and is not dependent on the degree of surgical resection. And this group also developed a new risk classification system that we don't traditionally use in practice now, but is an example of how we could risk classify patients and more uniformly perhaps group patients across the world. So again, the International Neuroblastoma Risk Group Staging System. This is pre-treatment now, before surgery, and it's based on really radiographic findings. So we now use something called image-defined risk factors, or if tumors are wrapping around really major blood vessels and may perhaps lead to a more difficult or risky surgery. So L1 tumors are localized tumors without these image-defined risk factors. L2 tumors are local regional tumors with one or more of these image-defined risk factors. Stage M tumors are those where it's not just the primary tumor, it's now moved on to other places. And MS tumors are, again, this very small, or this very select group of patients that are younger patients, less than 18 months of age, with either L1 or L2 tumors, or with metastatic disease that's very much confined to the skin and or liver and or a small amount in the bone marrow. And these patients do quite well. So these are examples of image-defined risk factors. I won't go through all of them in detail, but again, it really is about the tumors wrapping around really important blood vessels or local regional organs. And this slide just again compares the older staging system that we have, the INSS staging system, and the newer INRG staging system. And this slide is just an example of the risk group pre-treatment classification schema that came out of the International Neuroblastoma Risk Group, which is, again, very similar and includes age, histologic category, but now breaks down histology a little bit more into degree of tumor differentiation, and MICN amplification, LQ aberration, and ploidy. So as I mentioned on early in the talk, the neuroblastoma has a broad spectrum of clinical behavior, and we group patients as to either having low, intermediate, or high-risk disease based on the factors we just talked about to help us guide what kind of treatment a patient may need. Again, low-risk patients may have spontaneous regression of their tumor or just may require surgical resection. Patients with intermediate risk disease often receive chemotherapy and surgery, and those with high-risk disease receive multimodality therapy. So again, therapy is tailored according to patient risk, and we are continuing to try to identify treatment strategies with optimal survival rates and minimal toxicity. And the way we do this is through successive clinical trials. So clinical trials in neuroblastoma really tailor treatment according to predicted behavior based on clinical characteristics and tumor biology. And a series of clinical trials for children with low, intermediate, and high-risk neuroblastoma have been ongoing for decades to identify treatment strategies with optimal survival rates and minimal toxicity. So I wanted to touch on a few trials over the years that have led to how we currently treat our patients. So for low-risk neuroblastoma, there was a trial, P9641, where the objective was to demonstrate that surgery alone would achieve 3-year overall survival of greater than or equal to 95% for patients with asymptomatic lower stage tumors, these INSS stage 2A and 2B tumors, where asymptomatic patients would receive surgery alone and symptomatic patients would receive a small amount of chemotherapy plus surgery. And what we saw was that this was possible, that we could maintain excellent survival with decreasing therapy in a subgroup of patients. So again, patients with low-risk disease may just undergo observation, surgery, and a small group of patients may require some chemotherapy. And then moving on to intermediate risk neuroblastoma, I wanted to touch on the study A3961, where the objective was to determine whether a 3-year estimated overall survival of more than 90% could be maintained with reductions in the duration of therapy and drug doses using tumor biology-based therapy assignment, where those with favorable biology received 4 cycles of chemotherapy and surgery, and those with unfavorable biology or an incomplete response received 8 cycles of chemotherapy and surgery. And again, what was seen was that we could reduce therapy while maintaining excellent outcomes in subgroups of patients. And next, another intermediate risk study, COG ANBL 0531, was now a response and biology-based trial for intermediate risk neuroblastoma. And the objective here was to reduce therapy for subsets of patients using a biology and response-based algorithm to assign treatment duration while maintaining excellent 3-year overall survival of greater than or equal to 95%. And what was seen was that based on this response and biology-based system, that patients could receive anywhere from 2 to 8 cycles of chemotherapy, depending on their response, and surgery, and excellent outcomes were maintained for the majority of patients. And now we move on to high-risk neuroblastoma. And again, this is what I like to tell families as well, too. I know many families are like, oh my goodness, we're put in this high-risk category. But I like to think of it as a way of risk helps us define how we need to treat a patient and how much therapy we need to give a patient to try to get the best outcomes that we can. So an earlier study, CCG 3891, conducted by Dr. Methe, who you'll hear from today as well too, looked at whether the addition of myeloablative chemotherapy plus autologous stem cell transplant versus continued chemotherapy improved outcomes in patients with high-risk neuroblastoma. And what was seen was that this high-dose or myeloablative chemotherapy and stem cell rescue did improve event-free survival in patients after induction therapy. And then moving on to the COG study ANBL 0532, ANBL 0032, now looked in the post-consolidation setting and saw that does the addition of immunotherapy or targeted immunotherapy targeting anti-GD2 on neuroblastoma cells, plus the differentiating agent isotretinoin, improve outcomes compared to receiving isotretinoin alone in the post-consolidation phase. And what we saw here was that the event-free survival and overall survival is improved with immunotherapy plus isotretinoin following autologous stem cell transplant. And that is our current standard of care in the post-consolidation setting. And then moving on to ANBL 0532, this now looked in the consolidation setting whether getting 1 or 2 transplants was better for patients with high-risk neuroblastoma. And what was seen here was getting tandem or 2 autologous stem cell transplants improved event-free survival, especially when followed by immunotherapy. So this is our current COG-based standard of care treatment for children with high-risk neuroblastoma. So as you can see, patients undergo a biopsy at the very beginning to help with the diagnosis, receive 5 cycles of chemotherapy and surgery during induction. Consolidation consists of tandem autologous stem cell transplant. There are some subsets of patients who may receive 1 stem cell transplant, and then radiation to the primary tumor or any sites that may be positive on MIBG scan prior to consolidation. And then the post-consolidation phase includes the targeted immunotherapy or anti-GD2 antibody and cytokines and isotretinoin. And Dr. Matthey will go through some more of the current COG trials and directions for the future. So this slide just shows the successive increase in overall survival for COG patients with high-risk neuroblastoma over the time span of 1990 to 2015. And as you can see, we have made some strides in outcomes for our patients. However, there is clearly room for improvement, and this helps drive our current trials for neuroblastoma. And I very briefly just wanted to touch on some targeted therapies for neuroblastoma. As we talked about, anti-GD2 antibodies, which play a really important role in the frontline setting and in the relapsed setting for patients with neuroblastoma. MIBG therapy, again, different from MIBG scans, and Dr. Yannick will go into this in more detail. And ALK inhibitors, one of the other targeted therapies that we can use in neuroblastoma. So anti-GD2 antibodies. So GD2 is a diasialoganglioside that's essentially ubiquitously expressed on neuroblastoma cells. So again, a targeted therapy for neuroblastoma. And there are a variety of anti-GD2 antibodies. Many are familiar with dinutuximab. Dinutuximab beta is used in Europe, and these 2 antibodies are chimeric monoclonal antibodies. And then there's nexitamab, which Dr. Morgenstern will go into in a little bit more detail as well too, which is a 3F8 humanized antibody, and also being used in various settings for neuroblastoma. And the side effect profiles really reflect sort of the off-target effects of the drug. So GD2 is also expressed on some of the long nerves in the body, so pain is one of the big side effects of this drug. And also allergic type reactions are important side effects that we review with families. MIBG therapy, again, is a similar concept as the scans, except there's a higher radioisotope attached to the MIBG tracer, allowing us to provide some localized radiation to areas of disease. This generally requires a lead room or shields to protect families and staff from radiation exposure, and generally requires stem cell rescue afterwards, as it can impact the bone marrow. And it is currently being studied as part of frontline therapy for high-risk neuroblastoma in the current high-risk study. And this is just an example of a scan. I'm sorry, the images are not the best, prior to MIBG therapy. And then one thing I always bring up to families is, we get a scan wall after they get their MIBG infusion prior to their discharge, and often or what we would like to see is the lesions look brighter, or it looks a little bit worse than their baseline scan, but this is what we want to see. We want to see the uptake in the areas of disease, and then we get a follow-up image 6 to 8 weeks after therapy when the MIBG has left the system, and to see what the response has been. And this is just another example of a patient who's had a very nice response to their MIBG therapy. ALK, we talked about ALK potentially leading to familial cases of neuroblastoma. It can be in the germline, that's very rare. However, in the tumor, we can see ALK mutations, and that does not mean that it's the hereditary form. It can just be in the tumor cells. And we see that in about 10 to 15% of children with high-risk neuroblastoma. And we do have targets for this. So crizotinib is an ALK inhibitor that has been investigated in neuroblastoma and was integrated into the frontline study for patients with ALK mutations at diagnosis. And we will now be using lorlatinib, which is another generation or newer generation ALK inhibitor for patients with ALK mutations. And I'm just going to end by talking again about some of the late effects, which you'll hear about throughout this conference. But we know that high-risk therapy is quite intensive and can impact various organs, can lead to infertility, can lead to neurocognitive effects and secondary malignancies, and we take this very seriously and, again, want to develop and eventually have therapies that have less toxicity. and improve and optimize the outcomes for our patients. So there is a study within the Children's Oncology Group that's led by Dr. Tara Henderson and Lisa Diller, and this is, again, trying to really understand what are the late effects in our patients. You know, it's great that we of course want to have optimal outcomes for our patients, but you know, what are these long-term effects, and are there ways that we could prevent some of these late effects? So they are investigating the late effects of patients receiving current era therapy, and we hope that we will be able to see some of this data very soon. So how can we continue to improve outcomes? By investigating novel therapies, collaborative work between those in the lab and those running trials, further refining risk stratification and having more precise treatments for our patients, learning more about biomarkers of therapy response and resistance and how that might help guide therapy, and again, collaboration across the world as well. So I wanted to end by saying thank you to everyone, especially our patients and their families who go through so much every day. And of course, the Children's Neuroblastoma Cancer Foundation and Pat for all of their work in putting together this wonderful educational conference. Thank you.
If anybody would like to come and ask questions, you can turn the microphones on and come up and ask.
Testing. All right. Good morning. Thank you, Dr. Desai, for your presentation and for all the doctors and families who are here. My name is Megan Nelson. I'm a parent out of Children's Hospital Los Angeles. I have a few questions, but I will just ask one because I know we are short on time. I'll go with your first slide. Your first slide, you mentioned that there is a higher prevalence of high-risk neuroblastoma in Blacks, and I think you mentioned Native Americans or Hispanics. Has there been any research done as to why this is?
That's a really good question. So, you know, there was a study done about, gosh, it might even have been about 10 years ago now, that showed that the prevalence was higher in Blacks and Native Americans, but the outcomes were the same as, you know, all other races and ethnicities in that study. But there has been some work looking at the genetics within certain patient groups and races and ethnicities that may impact why certain subgroups of patients may develop higher risk disease. So there has been some published work on that, and there is some ongoing work in that area. And there's some newer work looking also at, you know, even aside from race and ethnicity, looking at social determinants of health and, you know, the impact of, you know, beyond race and ethnicity, again, looking at how poverty can potentially impact outcomes for our patients, and there's some ongoing work in that area as well.
Good morning.
Hi, good morning.
My name is Kimberly Turner, and my daughter is 14. She was diagnosed at age 4 and relapsed at age 8. When she was diagnosed at age 4, they went back and forth between stage 3 and stage 4. They didn't know if they wanted to just hit it with everything or just treat it as intermediate risk. I'm sorry. I'm sorry. My daughter was diagnosed at age 4, and she relapsed at age 8. In the staging, they were kind of going back and forth. They didn't know which to put her in stage 3 or stage 4, but they did ultimately decide to do stage 3 and just do chemotherapy. And I always wondered if they had staged her at stage 4 the first time, which she had relapsed the second time. And they always say if they relapse one time, they will relapse again. So it's always in the back of my mind, will she relapse again, even though we had all of the stage 4 treatments. We had the chemotherapy, the stem cell transplant, but we only had one stem cell transplant because she only had 7,000 when she was supposed to have 15,000. And I did not want to risk, you know, doing 2 because it was such a hit to her body. So do you think if we had staged her at 4 the first time, would she had relapsed the second time?
Yeah, not knowing all the other characteristics of the tumor and just knowing the stage alone, I think that's hard, and I think there are patients that could fall into either category, and we try to use all the other information that we have to pick what might be best in that moment of time, and sometimes we do want to give patients the benefit of the doubt and, perhaps try intermediate risk therapy, and there are some patients who progress on intermediate risk therapy and then go on to receive high risk therapy, so that does happen, and in fact, some of our high risk protocols allow that for happen, that someone may have received a little bit of intermediate risk therapy, and then perhaps there's something that made us think that they're high risk, or after they relapse may receive high risk therapy. But there's so much we still need to understand, even beyond what we do know when we classify certain patients into groups. And we draw, again, a line in the sand somewhere, but there is a little bit of give and take. But I think that's where all the research comes in to understand how can we be more precise for each patient. And it's just really hard, I think, to in retrospect, you think about these things, of course, as a parent, but I think we take whatever information we have at the time that we think will provide the best outcomes for patients at that time.
With her being treated as high risk, like if she does relapse again, I don't see any protocol for treatment if she relapse again. Is that like a doomsday type situation for us if she relapse again? Because they always say, like I said, if she relapse once, she'll relapse again. So it's always in the back of my head, but I don't see anything else that we should do if it does. Do we do the same thing over again versus something else?
So I think there is going to be a talk today or tomorrow, actually maybe tomorrow, on relapsed neuroblastoma, and that will probably hit some of these therapies. And you are correct in saying that treating relapsed high-risk neuroblastoma is difficult. There are certain patients that may have certain patterns of disease that might be easier to get rid of that disease than other patients, and we are learning more and more. There are a lot of clinical trials out there for patients when their disease comes back. We need more, of course, as well too. There's a combination of chemotherapy plus anti-GD2 antibody that's been very effective in the relapsed or in patients who may not have responded to therapy the way we wanted to, that I'm sure you'll hear through the other talks as well too. So my talk didn't really hit on a lot of the therapies in the relapse setting, but I'm sure you're going to hear more about that during the course of these 2 days.
I don't really like talking in front of people.
Pretend they're not there.
Easier said than done. So I saw that you mentioned the 11q on here, but I didn't see anything about the 1p deletion. Do you know where that stands?
Yeah, so that is also, I didn't hit on everything in the talk. They sort of, they can fit into this group of segmental chromosomal aberrations that we see, and I didn't pinpoint it here, but you're right, there has been some work looking at that and in the intermediate risk group of patients as well too.
Okay, good. I think that was all I had.
And if you have more questions, I'm happy to talk, if you don't want to talk in person too.
Okay, anyone else? Okay, yeah, go ahead.
Hello.
Hi.
My daughter, she had the tumor encapsulated. They surgically removed it before doing any chemotherapy. And it was decided not to do chemotherapy at the time. But then they found that, not through the MIBG, this was in Mexico, because we had they didn't see anything in the MIBG. But then in an MRI, they started seeing spots, and then it was decided that it was a relapse. Now, is that considered a relapse or not? Is it safe to assume that it wasn't a relapse, it was already there, like the metastatic disease?
I think that's, again, hard to probably answer without knowing all of the information as to how she presented, but, it's hard to say whether that was part of her original disease versus something coming back.
Okay.
Yeah.
Thank you.
And I'm sorry, I wanted to touch on one thing about the race and ethnicity. That I mentioned the paper about 10 years ago did talk about how the outcomes were the same even though the prevalence was different. But there was newer data presented in our recent oncology meeting that did show that outcomes were disparate in some of the current era high-risk trials based on race and ethnicity and poverty as well too. So again, still things that we're learning and different populations that we're treating. But those are patients who are treated on trial and trial data, whereas the study from about a decade ago was more of a population-based study of those who were on a trial or just on a biology trial and not actually on a clinical trial too.
I'm sorry, I have one more question.
Go ahead.
I have a million, but I will. Like she was saying, you guys said it's different with race. The first thing I did was Google this, like all parents do. And when you look it up, it says white boy's disease. I have a black daughter, so I'm looking like, wait, what happened? So why was it categorized like that, a white person? And then I see all different races with this particular disease. I don't understand why was it just in that particular race and to a particular sex group.
Yeah, you're right. And I think, at least in the studies, what they did was sort of use what we call like a composite variable, including both race and ethnicity, knowing that, there is some variation within that. And again, some of the genetic studies, because you're right, we group patients into different categories, but they may have an ancestry that might be a lot more broad than that. And that's where some of the germline genetic studies and their outcomes have been a little bit a different way to classify patients as well, rather than what someone reports as their race and ethnicity as well.
Okay.
Anyone else? Okay. Yeah, please do.
Thank you, Doctor. I'm a grandmother of a little boy that was diagnosed at a year. And, all the great information that you shared with us about diagnosis and staging and symptoms and all that. And my grandson is MYBG amplified.
Omicron amplified.
So it's genetic. And anyway, he had all the symptoms. My point in coming up with the question is really to declare, what is going on with pediatricians? Why aren't they doing early screening? I mean, we ran this kid around to pediatricians. He was given antibiotics. We went to emergency. They said, take your baby home. He's just a cranky kid. Teach him how to sleep. He had a 13-inch tumor between his liver and his kidney, and they couldn't diagnose that because they just refused to scan him. Yeah. So how do we pleaded, and here we were, rushed to Lurie's Children's in an emergency chemo and surgery situation.
No, I hear you, and I'm sure as a parent, as a grandparent, as a relative, you always wonder, could this have been diagnosed sooner? Why did this happen now? I will say, we're lucky in pediatric oncology that it's not common. As an oncologist, I think about cancer all the time, and, if a patient gets referred to me, I have my top X number of things I'm thinking of. I think when a patient comes to the pediatrician's office, there are a lot of things that you can think of, and some of the symptoms of neuroblastoma can overlap with a whole lot of other things as well, too. I remember as a fellow, one of the very first patients I consulted on was on a general pediatric service and with fever of unknown origin and a limp, and there were a lot of things that were being worked up at that time, and after some imaging, we saw what it was, and, again, I think once you know what it is, it's very hard to be like, how could we have not known sooner? But I think, again, cancer is rare in the pediatric population, and there are a lot of other things that we think about when someone comes in with generalized sick symptoms. And of course, I don't know the details of everything from your grandchild's diagnosis, but it's not uncommon for kids to feel unwell for a period of time before imaging is done, and we sort of go through a stepwise process often to try to understand what's going on. Yeah.
There's we have a pamphlet out in front. There's an organization out of California too that's kind of bringing up this exact same topic. I don't know how far they've gotten, you know, as far as trying to reach out to pediatricians or not. It's the Friends of Catherine Foundation. There's a pamphlet out front you can take. But yeah, that's basically the same questions they had, and how can they treat or teach the pediatricians, you know, to at least be a little bit more aware of what cancers might be out there in the children. So you might want to talk to, you know, the Susan Justo, and she can maybe help you a little bit more too.
And you're right, and I think, you know, a lot of subspecialties, you know, even beyond oncology, for what they do, will often have these seminars and, you know, discussions with pediatricians as well, and just to, you know, raise everyone's suspicions if they're coming across certain symptoms too. All right, thank you.
Sorry, Jen, I just want to make a quick comment,
Yes.
which is I think the other thing to bear in mind is although it's super distressing when there's delay in diagnosis,
yeah.
I'm not sure it's clear that it actually
impacts.
changes the outcome for the patients. You know, in adult cancer, we're very used to thinking, oh, we've got to catch it early because otherwise it will spread. And I think in neuroblastoma, it's a bit different in that it's predetermined to a large extent by the genes, by the genetics in the tumor, and it's going to do what it's going to do, and it's going to respond to treatment as it's going to respond to treatment. And as long as the child is well enough to receive the treatment, actually it doesn't matter from an outcome point of view whether they were diagnosed today or last week or last month. I don't think it changes that quickly.
Yeah, I just want to reiterate what Daniel said. You know, adult cancers are, you know, often environmentally driven, or, you know, there are screening procedures for breast cancer and colon cancer, and a lot of childhood cancers are very biologically driven. The tumor was going to do what it was going to do. I think that's what you're trying to get at Daniel, and that's why we have so much of the biology impact the way a patient is grouped into treatment.
Okay, one more question.
I was curious, are cancer rates increasing with either overall pediatric cancer or neuroblastoma? And if so, does it just reflect like population growth, or is it outpacing population growth?
Yeah, I have to say the most recent, I don't want to misspeak as to whether the rates are similar or are going up for the most recent data. I don't know if anyone in the audience would like to comment on that as well too, but you know, we don't screen for this, so it's not increased screening, but there might be increased awareness that may bring more cases to presentation. I know during the pandemic we were worried that patients weren't coming in, maybe perhaps as soon as they would have otherwise, that maybe could have impacted things as well. Right. Thank you.